Okay.
Vavikar sir, we are going live. Welcome, sir.
Okay. 5, 4, 3, 2, 1. We all are live now. We can start the session, sir.
Okay. Thank you, Rahul. Respected seniors, dear colleagues, friends, postgraduate student, good evening to everyone. On behalf of MOS and BOA, I welcome you all to this unique MOS BOA Journal Club webinar organized by Dr. Vaishal Kenia and his team, Dr. Sabyasachi, Jain Khatib, and Neeraj Israni. As you know, cataract surgery has been evolving and the expectation of patient has risen to the extent that despite good visual gain, he wants spectacle-free vision. Pre-op biometry is the crucial element to decide about the correct IOL power calculation. There are many factors which are contributing to the final outcome. To understand this, one research article in American Journal of Ophthalmology, which we are going to discuss today, to decide the most appropriate method and the formula to fetch the correct IOL power, especially in regards to the toric IOL power calculation. As you know, astigmatism is decided by not only anterior corneal curvature, but also by the posterior corneal curvature, which has been highlighted in this article. I am sure we will have a fruitful discussion today. We have stalwarts like Dr. Jivan Titiyal sir, Dr. Vavikar sir, Dr. Parul Deshpande, and Dr. Gore. I wish all the best to Dr. Ishan for today's presentation. I appeal to all the postgraduates and colleagues to attend such journal club meetings to update our knowledge and apply evidence-based medicine in our daily practice. Thank you so much for the opportunity. Over to Dr. Vaishal Kenia, please.
Thank you so much, sir. Sir, I would now request Dr. Himanshu Mehta, BOA President, to give his opening remarks.
Evening, Vaishal. Thank you very much. Thank you, Santosh, for being there and doing the opening comments. Almost everything has been covered up. In a rapidly advancing world of technology, we are becoming more and more dependent on maths and physics. And we've never been able to understand the structure of the eye so well. You know, all these formula could be the regressive formula from whichever person who has made it. All that will be discussed. But right now, I would just like to talk about something more important. I have a dear friend there, Dr. Titiyal, Jivan Titiyal, head of AIMS, and he's standing for the position of president of AIOS. I think there's no person better suited for this particular role than him. He has been in practice for such a long time. He has given such lovely talks. He's one of the best promoters of scientific knowledge and content. And we are proud to have a great association with him over the years. Dr. Titiyal sir, thank you sir so much for sparing your time at a crucial time when you hardly have any time. And with your routine schedule, which is so hectic. And Vavikar, who's a great friend, always a mathematical model. Great time to discuss the cornea, the front, the back, and the results. Over to you, Vaishal.
Thank you so much. So, without much ado, I would just want to emphasize that this journal club meetings are an exercise for the postgraduates, and I would want their feedbacks. What kind of topics do they want for discussion, so that in the coming journal club meetings we could have those topics. The next journal club meeting is slotted on 24th of April. So without further ado, I open this meeting, which is a third season. So Parul, who is the moderator, will open the meeting. Unmute yourself, Parul.
Yeah, sorry. Thank you, Vaishal. So we have Dr. Varshav Gore with me, who will be co-moderating, and my other co-moderators are Dr. Neerav and Dr. Neeraj and Dr. Zain. And the postgraduate student who is going to present is from MGM Hospital. Here, his name is Dr. Ishan, and he's going to present to us the comparative accuracy of Barrett's toric calculator with and without posterior corneal astigmatism measurements and the Kane toric formula. So, Dr. Ishan, can you share your presentation?
Yes, ma'am.
Yeah.
ma'am, is it visible?
We can see your presentation.
Good evening, everyone. The topic for discussion for today is comparative accuracy of Barrett-Storick calculator with and without posterior column elastic magnetism measurements and the Kane-Torick formula. So the topic is divided to three parts to make it simple. Barrett-Storick calculator with posterior column elastic magnetism measurements, Barrett-Storick calculator without posterior corneal elastic magnetism measurements, and the Kane-Torick formula. So the study was done by Dr. Yang, Dr. Byun, Dr. Kim, and Dr. Chung. So the study was published in American Journal of Ophthalmology on May 28, 2021 from the Department of Ophthalmology and Visual Sciences at Seoul St. Mary Hospital in Republic of Korea. All the authors have completed and submitted the ICMJE form and disclosure of potential conflicts of interest. So the introduction of the topic: cataract surgery is one of the most frequently performed surgeries worldwide, and advances in modern biometric intraocular lens formulas and surgical techniques have improved the accuracy of refractive outcome prediction. But the post-operative astigmatism is a major cause of poor uncorrected visual acuity. Hence, toric IOL were developed to reduce the post-operative refractive astigmatism, thereby overall improving the vision of the patient. The magnitude and alignment of total corneal astigmatism cannot be accurately predicted via anterior corneal measurement alone. We also need the posterior corneal astigmatism, which is abbreviated as PCA, leads to unanticipated refractive outcomes in toric IOL cataract surgeries. Therefore, PCA measurements have been evaluated using a variety of approaches, but it is best calculated with the help of IOL Master 700, which is produced by Carl Zeiss Company, a novel swept source OCT device. So the formulas: first is the Kane-Torick formula, second is the Barrett-Storick formula. The Kane-Torick formula is used to obtain the effective lens position using the PCA values, first by an advanced algorithm, second by theoretical optics, and third by artificial intelligence technique. And the Barrett-Storick formula also yields an effective lens position with an unpublished PCA prediction algorithm to predict the actual refractive astigmatism. So what does the previous study say? There was a large previous study done by Kane and O'Neill, which stated that the Kane-Torick formula was the most accurate among the 6 modern toric calculators, and the Barrett-Storick formula with predicted PCA was the second most accurate formula. So the aim of the study is to compare the accuracy of Barrett-Storick calculator with and without posterior corneal astigmatism and the Kane formula using the IOL Master 700 by the Carl Zeiss Company. And design is retrospective cross-sectional study. Retrospective means a study which uses existing data that have been recorded previously, and cross-sectional means a study of cross-section of population at a given point in single time. So the methods used: the study included a total of 79 eyes of 79 patients who underwent toric intraocular lens implantation by temporal clear corneal incision during uncomplicated cataract surgeries. So using vector analysis, the mean absolute prediction error was within plus minus 0.5 diopters, plus minus 0.75, and plus minus 1 diopter. They were calculated. And the mean analysis was designed to provide the clinical outcomes with each formula using the post-operative keratometry K1, K2 values and the measured post-operative intraocular lens axis. So the study center was Seoul St. Mary's Hospital in Korea. The study was done from 2019 to 2021. And the inclusion criteria were uncomplicated cataract surgery with a temporal clear corneal incision with insertion of either Alcon IOL, which is toric IOL, or the Technis toric IOL. And the exclusion criteria was any disease, any ocular disease of the cornea, example keratoconus or pterygium surgery, or any other ocular surgery which patient underwent, like pseudoexfoliation, macular degeneration if patient had, or any operation for retina surgery, and patient with underwent vitrectomy. So all these patients were excluded from the surgery, from the study. So this is a stepwise manner how the patient was evaluated. First step: pre-operative best corrected visual acuity was assessed with Snellen's chart. Second step: routine anterior and posterior segment examination was performed before the surgery. Topographic Schlemm-Flug corneal topography was used to screen for any irregular astigmatism of the patient. If patient had irregular astigmatism, patient was not included in the study. And all the patient underwent optical biometry, including measurements of PCA with IOL Master 700, and implantation axis was measured manually with the help of ToriCam application technique. And after the surgery was done, patients were followed up after 2 months. The actual post-operative refractive astigmatism was calculated by vertexing the post-operative manifest refractive astigmatism to the corneal plane. And for each post-operative follow-up, the exact axis of toric IOL was calculated using the Adobe company's Photoshop software. The post-operative refractive astigmatism, the prediction error, was then calculated as a vector difference between the actual value and the predicted value. So the difference, what we actually got and what we predicted, was the prediction error for the patient. So some simple important terminologies. The first is the mean absolute prediction error. Second is the median absolute prediction error. And third is the standard deviation of the absolute errors. Mean absolute prediction error means we calculate the actual value and the predicted value, and we take the and we subtract both of them. Whatever value we get, that is the error. And mean means we calculate all the errors and divide by the 79, because the total sample was 79. So we divide that number with 79. So we'll get the mean. And absolute means we do not consider plus or negative sign. So the meaning is the mean absolute prediction error. And second was median absolute prediction error. And the third was standard deviation. And the proportion of eyes within prediction error of plus minus 0.5, plus minus 0.75, and plus minus 1 diopter were calculated. To simplify things, the main analysis was designed to provide the clinical outcomes with each formula using the post-operative keratometry value, and secondly, the measured post-operative IOL axis. Also, the same procedure was performed using the pre-operative keratometry value and the intended IOL axis, which was referred to as real-world analysis. There were two analyses. For post-operative, it was main analysis, and for pre-operative, it was real-world analysis. So the patients were divided into two groups: with the rule astigmatism patient and against the rule. So whom we considered with the rule. So when the anterior corneal steep meridian was ranged between 60 degree to 120 degree, they were considered with the rule astigmatism. And for against the rule, the anterior corneal steep meridian was between 0 to 30 degrees or 150 to 180 degrees. They were considered with against the rule astigmatism. And the results of the study were: the study analyzed total of 79 eyes in 79 patients. So with the rule, corneal astigmatism were present in 41 patients, around 52% of the sample. And against the rule were present in 34 patients, around 43% of the sample. And oblique astigmatism were in 4 patients. So this is the baseline demographic of the eyes included in the analysis. First, the patients were total 79, sample was 79. With the rule were 41, against the rule were 34, oblique was 4. So important thing in this table is the K-flat values. 43.35 was the K-flat and the K-steep was 45.34. So I'll explain this diagram. So this diagram, it represents the pre-operative corneal astigmatism and post-operative refractive astigmatism. The left one shows the double angle plot. I'll just magnify and explain. So the left one is the pre-operative corneal astigmatism and the right one is the post-operative corneal astigmatism. So each ring here represents 1 diopter of astigmatism. And what we see in the blue is the 95% of the confidence eclipse. So 95% of the data were included in this eclipse. And yellow dots are the values plotted for each patient. And the centroid value, which is closer to 0 in both of them. So we compare with the pre-operative and the post-operative. We can see that the distribution is very wide in pre-operative patient, and in post-operative patient, the values reduced close to 0, and mostly they were less than equal to 1.5 diopters. And this is the same representation of the data in histogram. This is a cumulative histogram. The red bars here show the pre-operative corneal astigmatism of the patient. So we can see that 32% of the patient were between 0 to 1.5 diopters, and 0 to 2 diopters were for 53% of the patients. And the blue bars here represent the post-operative corneal astigmatism. So we can see that most of the patient were had one diopter less than equal to 1 diopter, which was 92% of the patient, and 100% of the patient were less than equal to 1.5 diopters. So this is the histogram showing the percentages of the eye with absolute prediction error of 0.5, 0.75, and 1 diopters. And we have compared the three formulas. The first one is the Barrett predicted posterior corneal astigmatism, and second is Barrett's measured PCA, and the third one is the Kane formula. So we can see that for the patients who have less than equal to 0.5, had almost 60% of the values were similar for all the patients, and for 0.75, around 80% of the values were similar for the patients, and for 1 diopter, 96% of the patients had same values. So the overall clinical outcome for each formula using preoperative keratometry and indented IOL axis. So the Barrett, here we can see that the Barrett's predicted PCA had the best prediction outcome for less than equal to 0.5 diopters. So for the value for the with the rule astigmatism, the main analysis for double angle plots measuring the predicted residual astigmatism with the rule astigmatism using the postoperative keratometry values and the intraocular lenses. So this is the double angle plot. We can see that the centroid value of with the rule astigmatism is very close to 0. It is 0.06 diopters for predicted, for measured, and for the Kane's formula. And this is the real world. That means the preoperative keratometry and indented value. Again, we have to look at the centroid values, which is 0.10 for the predicted, 0.09 for the measured, and 0.10 for the Kane formula. And the best outcome was given by the Barrett story calculator with measured PCA, which was about 65.9%. And for against the rule findings, double angle plots in the eyes of against the rule astigmatism using post-operative keratometry and measured post-operative intraocular lens. Again, we can see that the double angle plot was charted for all the three formulas. First one is Barrett's predicted PCA, second is Barrett's measured PCA, and third one is the Kane formula. So we can see that value of the centroid is slightly higher than that of the with the rule astigmatism. So, and this is the real world analysis for preoperative keratometry and indented IOL. Again, for all the three formulas, Barrett's predicted, Barrett's measured, and Kane's formula. So, and this is the tabular representation of the same data. So, inference from this table is that in against the rule astigmatism subgroup, Barrett's story calculated with predicted PCA yielded the best results with less than equal to 58.8%. So, things to keep in mind. No statistically significant difference in mean absolute error were detected between with the rule and against the rule, and all the three formulas showed a centroid error significantly different from 0 in with the rule and against the rule astigmatism. The percentage of sample having less than 0.5 diopter prediction error in Barrett's story formula was not significantly different when compared with Kane's formula with the rule and against the rule formula. Highlights of the study: there was no significant difference between the mean absolute prediction error calculated with two versions of Barrett's story, which is predicted and the measured one, and the Kane's formula. And the prediction error was above 0.05%. The Barrett story calculator with predicted and measured posterior corneal astigmatism yielded best results, with 60.8% having less than 0.5 diopters of prediction error in the main analysis. And the real world, meaning in the preoperative, the Barrett story formula calculator with predicted posterior corneal astigmatism shows the best result, with 53.2% having less than 0.5 diopters of prediction error. So advantages of the study were, it's the first study directly compared the updated Barrett story with the Kane's formula using IOL Master 700, and the results showed prediction error of less than 0.5 and 60.8% of the patients. But the limitation of the study was that the study used two different IOLs. However, Abulfia and associate addressed that if even if the more than one IOL is used, it is acceptable if the data is limited, the number of samples is limited. So discussion. All the three formulas, including Barrett's with predicted PCA, Barrett's with measured PCA, and the Kane, have showed comparable and excellent accuracy with no significant difference. And the best results were shown with the Barrett's Storic formula with predicted and measured values, 60.8% having less than 0.5 diopters. And for preoperative in the real world analysis, Barrett's Storic calculator has also given a good result with 53.2% having less than 0.5 diopters of error. So the difference between the results for main analysis, which is the post-operative, and the real world analysis, which is pre-operative, signifies the importance of accurate post-operative IOL access and proper measurement of individualized surgical induced astigmatism. So the centered errors were comparable, around 0.14, 0.11, 0.11 for Barrett's predicted, measured, and the Kane-Toric formula. So the analysis of the clinical outcomes in subgroups was based on the orientation of the anterior corneal astigmatism and the centroid errors of with the rule, which was slightly lower. So with the rule astigmatism, the centroid error were closer to 0. That means for with the rule astigmatism, the results were more accurate than the against the rule astigmatism. Conclusion: the Barrett's Storic formula with and without posterior corneal astigmatism measurements using the IOLMaster 700 and the Kane-Toric formula yielded accurate and comparable outcomes in the single surgeon analysis. Barrett's classification method: study question was well defined. Study population inclusion and exclusion criteria was well defined. Study period was well defined. It was a retrospective cross-sectional study. And assignment: all patients were matched for baseline parameters and follow-up interval. Assessment: measures of outcome were appropriate and no inter-observer variability was seen. Results: measurements and results were obtained using IOLMaster 700, and interpretation: the probability value was above 0.05, which is not statistically very significant in the study. And extrapolation: since the study was done in on Asian population, adequate sample size can be extrapolated to other Asian countries. Thank you.
Thank you, Ishan. Wonderful presentation. And with this, me and Dr. Gore would take the discussion forward. So I welcome Dr. Sen Gupta, who is our statistical expert, who is joined later. And I would like to ask Dr. Titiyal, sir, what is his opinion about this article? So is it that we can take home the message that Barrett's is the formula to go ahead?
Ishan, stop sharing the screen, please.
Yeah. I think first of all, I'd like to really congratulate Ishan for a wonderful presentation. I think he did a very nice job. He took us through the entire study in a very, very nice manner. He defined the areas which could be discussed subsequently. And personally, like to thank the MOS and BOA for this wonderful step taken for doing a journal clubs, because that gives a lot of insight into a futuristic thinking for a younger generation also. As far as study is concerned, I think it is a very good study which has been published. Few things are very important. We realize all the modern IOL calculation even for a non-toric or toric are equally comparable, the newer generation formulas. And fortunately, we have access to all the formulas nowadays. So you can go to APACRS website or AACRS, you get these formulas and you can calculate very, very nicely. So one thing is very important here to realize. This was an almost 2-year study from 2019 to 2021. And surprisingly, the number of cases are quite less. We would have, would have a better result if would have, hundreds of cases on either side. And to look into our group of patients, we'll have a more of patients against the rule astigmatism. Well, it's almost 50% in this group, but it is surprising. Maybe the age group was a little younger in these patients, where you have more with the rule patients here. And according to whatever way we think, when we compare the cases here, few things are important. One, which is not highlighted here, I presume the incision would have been 2.2 or 2 millimeter, which is not mentioned here. It could have been any size of incision, which will all make a difference here also. And second, the type of lens they have used, which they have depicted also. But in Technics grouper lenses, was it the older Technics toric lenses or newer ones? Because the rotation with the older generation toric lenses are more than the newer generation Technics toric lens, where they have modified the haptic, it's become more, sturdy, and it gives a very nice in the bag stability. So that was there, but I think one point they have taken good is 2 months. So by 2 months, things will be stable in either group of cases. Otherwise, it's a nice study, and I think we should be very comfortable that all the IOL powers are quite good for us. Barrett 2 is a universal power, and for us also universally we use this power for all the cases.
Yeah, thank you, sir. Dr. Vavikar, sir, what is your take on the article?
Good evening, everybody. Good evening, TTL, sir. First of all, thank you, team General Club, Vaishal and Parul, for giving me this opportunity. And Ishan, what a nice presentation. Very crisp, to the point, and it went in a really nice flow. Now, I would like to agree with TTL, sir, most of the points. I will just elaborate on some points. Is that one of the points he said is that we did not know how the sample size was arrived at. That is very important, because the percentage of population of WTR and ATR, it differs with age, and that is a very, very important factor. Second thing is that pre-op data, how it was taken. If we feed in wrong anterior astigmatism, we are going to get a wrong result. So whether 2 instruments were used, 3 instruments were used, whether Barrett integrated K were used, or the average was chosen, whether how they were assessed, these are the best readings. There is no light on that. So if instead of 0.5, suppose instead of 0.7, let's say your astigmatism is 0.9, everything would change. Effect of surgical induced astigmatism has not been considered fully, because we know that centroid SIA has got very less effect, and it has been a clear corneal incision temporal. So SIA would be very, very less. But once in a while, we do cases where the SIA goes out of our control, and therefore calculation of SIA in each patient would have been important. And those patients where the SIA was not close to what was presumed, those cases should have been eliminated, because they will, unnecessarily undermine the data of one of the, formulae. So I think otherwise, okay. Another point is that only 50% of the patient had post-op astigmatism of less than or equal to 0.5. Nowadays, I don't think that is the situation. Most of us are having loads and loads of cases. I think 80-85% probably. I don't know the exact number, where the post-op astigmatism is, between 0 and 0.5. That was one thing which was likely surprising. But overall, Ishan, very good presentation, and thank you very much.
Sir, if you see in this study, they had shown that about 92% had less than 1 diopter of astigmatism. So they had about 8% of the patients who still had eyes who had more than 1 diopter, so up to 1.5 diopter. What could have been the reason to get this kind of a erratic astigmatic error in these eyes?
That question is for me.
Yes, sir. Anyone, both of you.
Yeah, see, basically, Parul, if we don't measure preoperative astigmatism properly, we need to have 3 instruments and best reading of each instrument, and that needs to be compared, and whether the axis was varying by more than 5 degrees or 10 degrees, and whether the power of the cylinder was varying by 0.1 or 0.2, all these things make a difference. That is one of the things. So instead of 0.7, you feed 0.9, or instead of 0.9, you feed 0.11, you already started with an error, because the anterior astigmatism error gets multiplied because posterior is predicted according to anterior, and that's why the situation was more haywire. Second thing is that, once in a while, see, SI is a very funny thing. In SI, if you want to get a same SI, you have to put a knife every time in the same way, get inside and get out, and which is humanly not possible for everybody. And that therefore we are going to get SI patients where the SI suddenly shot up to 0.75, and that can be one of the causes why some of the patients are gone awry. the type of blade which was used, using a diamond knife, using a metallic blade. One blade was used for how many cases? If you use the same blade fifth time, the SI index is going to be different. What is the grade of the cataract? If the hard cataract is used, obviously it is going to disrupt wound architecture. And then again, you're going to have effect on SI. So all these factors, they need to be ruled out, and then only the formula need to be compared. That is what. And what my objection, what you said precisely, what my objection is that if we are going to get 50% of the cases, we are going to get more than 0.5 astigmatism, then toric trifocal or toric EDOF lenses, we just cannot implant only. We have to have less than 0.5.
Yes, sir.
I think I agree what Bhavekar discussed this, and today's time, if you consider 0.5, 0.75, 1 diopter plus minus, then that's not good for a toric IOL. That may be okay for a monofocal lenses, because there you might leave cylinder other power. We should have gone for a 0.5 or less to actually see the outcome in these cases, and that would have been checked with the uncorrected visual acuity. Because once we talk about astigmatic correction, we should be talking on uncorrected visual acuity, because that would be the final outcome variant in these cases. But if you take +1, plus minus, and your range of astigmatism is less than 2 diopter in most cases, then it is a total failure of this particular implantation of toric IOLs. So I think they have not done a proper selection of cases and proper selection of the toricity of these eyes. That's why they've got so much of variation. Correctly pointed out.
Thank you, sir.
Dr. Parul ma'am, can I say just
Yeah, yeah.
comment?
Yes,
So,
Brian.
so actually, this the analysis that they have given is not the post-operative residual cylinder, but it is actually the prediction error by vector analysis. So, that is the reason probably why the results are so low. So they have minused the post-operative error vertexing at the corneal plane from the pre-operative prediction error, and that is why the error has become slightly more. And the second thing, Vavikar sir, to answer about SIA. So if you see, they have done two subset of eyes over here. One subset is called real world data, and the other subset is called as the actual data. In the actual data, they have taken the post-operative keratometry and fed it into the calculator, and they have taken the IOL actual axis of placement. So it will even consider for if there's been a shift of the IOL placement, and they have incorporated that into the calculator. So that is why in that situation, they have negated the effect of IOL rotation post-op and the effect of SIA also. And they have done both the analysis separately.
Zain, if I may, see, the effect of IOL rotation will be taken care of.
Right.
But effect of SIA, I'm doubtful about it, because it will not be taken care of. We have to have.
They have entered the post-operative keratometry. So they have negated SI in that sense now, because the keratometry pre-operative they have not taken. So they have taken one with pre-operative and one with post-operative.
Yeah, I agree with you. I saw that, but I still have a doubt whether that will, we are unnecessarily complicated in the matter. Instead of that, calculate SI in every patient, and in those patients where the SI is very high, just delete those cases. I mean, it's just one way of thinking.
And even
Yeah, I'll just add one more factor to it. Okay, we are now talking about less than 0.5 diopter of astigmatism. We need to now have proper lens labeling up to the dioptric power and more accuracy, and the lens design has to be defined, because we want to go still lower, then these factors would come into play.
Absolutely. Very valid point.
Yeah. I think what Dr. Jain talked about is a very important point. The entire study, they have thought about what is the predictable astigmatism of this particular calculation and what was the post-op outcome, and that was compared grossly. And in that way, yes, then the error will be seen. Otherwise, if they would have given actual, refractive error would have been different.
Okay. Yeah. Sir, I would like to ask a question about, should we go for a posterior corneal astigmatism measurement or versus prediction of differential method? So if both are having equal results,
And if you don't have the facility of IL master 700, so can we rely on prediction method also?
I, I think if I answer that, as far as I'm concerned, if I'm going for a, premium IOL, like trifocal toric lenses or a EDOF toric lenses, there I'll definitely go with the, posterior corneal curvature assessment and take that formula. If it's a simple monofocal toric lens, I can go with the, without looking into a posterior corneal curvature also, because not really going to make a too much a difference there. For a trifocal or a multifocal lens, it is going to make a difference. Even a 0.3, 0.25 or 0.5, it's going to really change the, post-op uncorrected visual acuity in these patients. I think there it has a value.
Sir, if you are going with a measured method, then what is your preferred instrument?
As far as I am concerned, I use IL Master 700 for most cases. Now recently we are using other methods also, like Anterion, which gives you assessment for that also. But anything OCT based imaging where it gives you actual the posterior toricity will be a good assessment.
So, sir, do you involve even a shine plug technology in this?
Yeah, in some cases, because as Bhavekar nicely highlighted, we need to have at least two instrumentation giving the profile of astigmatism. And it is very, very important if you are really going for premium IOLs. And we look for not only corneal, posterior corneal astigmatism, you have to look for a amount of cylinder anterior with the rule against the rule, and the axis of a steeper axis has to be checked in 2-3 instrumentation, and there should be matching.
Yes. Dr. Vavikar, sir, you have any comment? What is your preferred method of measurement of posterior astigmatism? So, do you go with only the TK value which is provided with ILMaster 700 or any other instrument that you look forward to? Yeah.
Yeah. See, what I agree with TTL, sir. But at our institute, what we practice is that we measure all the three, predicted as well as measured. And the measured is by ASOCT or SSOCT as well as by shine plug, and we take whatever is the best. But what is the important point, take home message, is that in most of the cases there is not much of a difference. So if you go by measured, or if you go whatever the end result of the study is exactly what our observation is. So even if one does not have IL master, that's fine. He can go by a predicted method. It's only when you have a complicated eye, like post refractive surgery and all this, that is the time when all this instrument matters.
Absolutely.
So the only one thing which I have observed, so I use an ILMaster 700 and a shine plug pentacam. And to my surprise, I always use a measured method. And when I use a TK value, when I use the ILMaster posterior PCA and I use a shine plug, I find that the posterior corneal astigmatism by both the methods are near what similar. I don't find a lot of variation in these two instruments. So I think both of them measure adequately the PCA. And I really don't go with the predicted PCA. I usually always go with measured value only. Okay, with this, I think go back to, sorry, somebody wants to ask something?
Yeah, the point highlighted by Dr. Vavikar was that in normal cases, measured or predicted will give you the equal results. It's in cases with post-refractive cases or keratoconus cases, there is where you need to take the measured values, especially where the PA ratio is altered.
Yes. Okay. Yeah, sure.
That's one query, Parul, I want to ask Dr. Bhavik. Like, if we look into age as one of the factor, as we operate younger patient, they are most maybe towards the with the rule astigmatism. We all understand with the rule slightly slowly shift to the against the rule as the age advantage. So what about taking into consideration the Bayer's nomogram, which also looks into the age as a factor, and it also compensates the with the rule patients. And if I think, if I operate younger patient, less than 45 or 40 sometimes, younger pediatric patient, there this formula nomogram may be a good idea to use. What do you think?
Yes, sir, I agree with you. That is definitely a concern. See, normally not all the patients, they travel from WTR anterior to ATR anterior, and only 50% travel. And that's why it's like, anybody's guess what to pick up. But as a rule, when the patient is like 85-year-old, we know that whatever travel has happened has already occurred. So you can go back on target. Whereas suppose somebody is, 45-year-old, then it is better to undercorrect ATR anterior and slightly overcorrect WTR anterior. So in that case, Bayer's nomogram comes into play.
I think with this, we just move slightly back towards the article, and I would like to invite Dr. Sengupta to share his comments about this article, especially mm, uh, the importance, whether we should take back any message home. Dr. Sengupta, are you around?
Yes, yes. I'll,
Yeah.
So mainly there are three groups here where the Barrett's is being used for two groups, where one group is with a predicted PCA and the other is actually with a measured PCA, and the third is the Kane toric calculator. So overall, they're showing that a mean absolute prediction error is only about 0.2 to 0.3 diopters in all the three groups, which is overall, I think, quite small. But then, when you use the predicted values, then those numbers go up, like Zain was telling us. But overall, the actual errors, even in these cases, seem to be still within acceptable limits, even if you look at the 95% confidence intervals. Again, two outcomes have been carried out. One is the clinical outcome, the other is the real world outcome, right? So clinical is again based on the predicted, okay, this is the predicted and actually what happened. And the real world is, this is the predicted and, what the machine was actually telling might happen. So yeah, it's quite relatively complicated kind of analysis here. They have actually given us rationale for the sample size calculation, and that is 32 in each group. And that also seems to be pretty all right. And they have taken eyes which have about 2 diopters of anterior corneal astigmatism as inclusion, though they haven't actually mentioned it. But when you look at the results, you see that the mean K, steep flat K is 43 and steep K is 45. So it's about 2 diopters of astigmatism is generally what they have taken. And I think that's pretty much how we choose patients for our toric lenses. So, I think the overall crux of the matter is, should we use the predicted value, and is it good enough to use predicted value, or should we only base our toric calculations based on the actual values? So this article seems to tell us that it doesn't matter, that both are the same. So then if so I think my take home message is, if you have the facility, you should still carry on doing the actual readings and not merely base it on the predicted values. But then you'll realize over a period of time, if you look back at your data, that the predicted and the actual are very similar to each other, and that there are not going to be too many refractive surprises. So for somebody who doesn't have access to an IOL Master 700 or a Pentacam, using the values, the predicted values is pretty all right. However, like Tityal sir said, that if you're actually going for a trifocal toric, and like Dr. Bhavikar said, it's those are the patients who are more demanding. This is post LASIK, and I still want 6/6 and don't want to wear glasses. So a combination of that, and that's a relatively small data set of what all our patients are. So that is a perhaps a younger individual who is post LASIK and whom we are looking to do a toric, a trifocal. I think that is perhaps a group of patients where we still need to bank only on the measured values, but pretty much for all other things. So that's like 95 out of 100 patients. The predicted values are pretty good enough.
Dr. Sengupta, in these 79 eyes, I presume they must have taken both the eyes of the patients. They have not actually mentioned. So do you think we do have a bias here in
No,
terms of results?
Parul, they have mentioned 79 patients, 79 eyes.
79 eyes or 79.
Yeah.
Okay, sorry. So I have missed it. So they have only taken one eye of each patient. Yeah.
So overall, it's pretty sound, I think. It's not too many. I don't say this very often, but overall it seems
So
to be quite
they
sound.
do have the keratometric readings, which are very, very away. So they have something going as far as at 50, So in these extreme values, do we really think that Barrett still holds true and gives us a good outcome, or we should look at some other methods like ray tracing methods? There are a lot of methods which are available. So is there any, anybody has the experience with other methods besides IOL Master and besides Barrett's or Kane? Any other experience, with any other formula?
I do not have any experience with others, but I have implanted 29 diopter Alcon toric with 4 diopter astigmatism anterior, and Barrett was bang on target. Meaning, like only one case I have. So and myopto we are getting lots where the IOL power is 15, 16, 17. But very high, like 6, 7, I have not implanted with very high cylinder. The moral of the story is that Barrett works so well that we do not have any need to look at others in normal eyes.
I think, in such a high, steeper cornea, sometimes pentacam is a good way to look into these cases, because that will also give you the entire profile. And in the past, before Barrett Universal came, I was very fond of using Haig's formula there, which will be, taking the entire range, and especially post-refractive. I used to really, depend on a Haig's, for LASIK, myopic LASIK, Haig's L, or even for a post arcade used to be given very nice results. But now, as Bhavikar said, we almost depend on a various formula nowadays. But still, I compare these two formulas.
Sir, I think most of the people who are here now, they don't have access to the
IOL
IOL
Master.
Master. So they usually have what is available as a portable machine. So I think either it's a NIDAC or it's a Tomy Swept Source technology. So does it compare equally with IOL Master? Any experience of any of the members? Because that's important for people who are using that machine. So we are talking about IOL Master 700 here because the author has used IOL Master 700.
Yeah. Yeah, actually, like we have not done any such comparative studies. Like we have IOL Master 700, we have the other machines also, like Lenstar 900. Recently, we have started using Anterion, but again, they are the same principle. But those cases where you can't actually get the optical biometry, which is the challenge sometimes for getting accuracy in not only keratometry but for axial length also. So we classically depend on a immersion biometry in these cases, which also gives a good results with a calibrated machine for you. For a keratometric values, then you have to depend on other methods, which can be simply any topographer, or if you have calibrated auto K also, sometimes even that is useful for people who don't have other devices. But classically nowadays, people, if you are going, as I said, in premium IOLs, then you have to look for some assistant from other areas where they can give you these biometric readings.
So, sir, if I understand the available machines which we have, which measures a TK or a PCA in IOL Master, I'm not talking about shine plug. So we have optical biometer. So we have IOL Master and we have Anterion. So does Lenstar and Tomy also give us these values, or they are not giving us those values? Because Tomy is also SS based technology, but I'm not sure whether it gives you
They are there. You have to go through the nomograms, which will give you, then calculation of various parameters, and gives you the some sort of predictable what would be the PCA in those cases.
So we use a predicted method. We are not using
Yeah.
the measured method. So we
Yeah.
only have I think IOL Master, and we have Anterior, which is giving us a
Yeah.
PCA in the optical biometer. Okay. Oh,
The
anybody else?
measurements done, I would just like to highlight the measurements done by the IOL Master 700 are just 6 radial scans. So there are just 6 points, whereas the Anterion is more densely taking more scans.
Peripheral.
So the measurements of the posterior value are much better, but there is no head-on comparative study which I'm aware of at the moment.
And what about the anterior values? Anterior values variability sometimes is a little bit more with IOL Master 700. I'm not sure, but when I find that
Quite comparable.
I always compare it with my topographer, and sometimes I see that the IOL Master 700 is giving me a little higher values, and when I look at my topographer, it does not give me that value.
Parul, but all the machines, see, IOL Master 700 measures at 2.5 millimeters.
Yes.
Other machines measure at different, so the
Yeah,
K values will
1.5, yeah.
differ. But as Dr. Vavikar said, we need to use at least 3 machines and compare it whether the K values, the quantum of astigmatism is the same or not. So if you're getting a variable result, that means your eyes are more dry. You need to measure it on some other day.
Can I add?
Yes, sir.
Yeah, sure.
I'll just add to what Vaishal said. Is that IOL measures anterior K by telecentric keratometry, and it is really very accurate. It is possible that you are comparing two on different radii of curvature, like IOL on 2.3 and 2.5, whereas topo is on 3 millimeter. That's why you are getting different readings. Point number 2 is that IOL 700 does not actually measure posterior K.
Okay, absolutely.
It is anterior K, and it takes corneal thickness into consideration, and that's why it extrapolates. So it is strictly not a measurement, even though it is accurate. But when we are saying measured, actually it is not measured. It is still extrapolated only.
Okay. Anybody else has any questions?
I have a question for the panelists. So they have not taken in this particular study much of oblique astigmatism cases. I think Vavikar sir, I had spoken once to you, and you, I think, had told me that in oblique astigmatism cases, the measured keratometry works better than the predicted. Or do you have some inputs, both the panelists, on oblique astigmatism?
Absolutely.
So, sir, you want to say, Tital sir, you want to say something?
So, as far as number of cases are concerned, as it is also there were only 4% in this study. We also have a very less number of patients with these oblique astigmatism, and with this proper calculation, the outcomes are almost similar than routine, with the rule against the rule cases. But only problem I have faced in some cases where we could not actually capture the correct axis in these patients, because if you take 2-3 instrumentation to measure them, in oblique is the one where you can have a variability. Otherwise, in a routine with the rule against the rule, normally you get the same reading in a 2-3 instrumentation. So there you have to be little careful, and I doubly make sure that it's correctly taken. Firstly, in a pre-op, when actually I'm doing surgery, I keep asking, is it the right axis? Because that is little odd from your routine things. And that is important. Sometimes, we have made a mistake in the OR team. There, you have a one, actual axis of implantation. One is the reference axis. So sometimes by mistake, somebody tells you reference axis, you're going to put lens in a different area, because you'll think, oblique is not a routine area. So that is the only point I make sure I am correct on those areas. But outcome-wise, I have not seen a huge difference nowadays with the modern calculations.
Dr. Vavikar sir, in this study, they have seen that those patients who had against the rule astigmatism, there were higher prediction errors. So, is there anything that we can do in our this thing that we get the prediction errors smaller, because we see a higher population of ATRs? So, what can be done so that we can get the prediction error to as minimum as 0? So, is there anything that we can do?
Actually, that was a little surprising to me, because there are several studies, and the important study was done by Miyake. He said that the posterior corneal astigmatism is always of the magnitude of around 0.2 to 0.25, when the anterior corneal astigmatism is ATR. And therefore, theoretically, the prediction error should be much more tight, less. And that is what our observation is also in our practice. So I do not know why that observation has come, but I did not have any explanation. So I did not mention that point. In WTR, on the contrary, the amount of posterior corneal astigmatism is directly proportional to the anterior corneal. So suppose you have one diopter, WTR, you will have say 0.5. If you have 4 diopters anterior astigmatism, then you will have maybe 2.5. So there is a proportion going on there. In ATR, ATR anterior, whatever you do, it is always 0.2, 0.25. And 0.2 and 0.25, like, these are subclinical differences. And that is why our results with ATR actually are better.
Okay, so now taking this forward to the abnormal eyes. So now we are seeing more of a post-refractive surgery, post-RK. and patients with early keratoconus. I think mild keratoconus we are including in the toric groups. So do you have any pointers, or anything that you can suggest so that we get less and less of residual astigmatism in these patients?
Yeah. So what we do is that we do go by two methods. Number one is Barrett TK. Barrett TK or measured PCA Barrett is shown to be 12% more accurate than predicted Barrett in abnormal eyes with all these eyes. Okay. Now, post LASIK, if it is a case like post LASIK, post myopic LASIK, post hypermetropic LASIK, the situation becomes very simple because you can apply, or you can apply some ratio by which you can correct the corneal power or the Gulstrand ratio and get a power. So that is how IGCL works. But suppose you have a patient where there are multiple procedures. That means patient had LASIK, then he had corneal ectasia, and then after that he had a C3R. Okay. So then it becomes very difficult. These are the cases where we go by ray tracing. That means you measure the anterior corneal curvature, you measure the posterior corneal curvature, and you feed in axial length and you get the power. Now, having said this, I always go to ACRS website, and the most important point in filling that form is fill in as much data as is available to you.
Absolutely.
And then you will get a power by each and every formula, and you will get power by average. So what we have is that we choose average, but slightly shifted towards Barrett TK or Barrett measured PCA, and that is how we go about.
So do you believe, do you feel that patients who have irregular corneas, a topographic astigmatism is more to rely on? I'm not talking about the spherical equivalent that you get. What I'm focusing on is that if the patient has astigmatism, would you correct the astigmatism which you see on topography,
Very
or
good
you see it on IOL master or optical biometer?
Yeah, it's a very, very good question. I will always consider topography. If the central 3 millimeter has regular astigmatism, then only it is worth trying toric IOL. If the patient has got a very eccentric cone, and then there's no point in going for a toric IOL. Secondly, when we are doing such complicated cases, we always tell the patients that we are not getting rid of the astigmatism, we are debulking the astigmatism.
Okay. So Dr. Tityal sir?
Sometimes, what we talk about, one point which came out nicely was doing a ray tracing in these cases. So not only to get the corneal profile, it is also to look into the aberration profile of entire eye and corneal aberrations. And if you have a huge corneal aberrations, which we are discussing, may not be a good case for a toric implantation. Like early keratoconus or post-CXL eyes, or a patient who undergone refractive procedures. There, as Bhavikar nicely highlighted, we can simply use a monofocal IOL or decrease the bulk of a cylinder if possible, then see how patient does. But given an option, I might put only the monofocal lens, wait for an eye to stabilize. Then if needed, go for a topo-guided corneal ablation in these cases to take care of corneal surface irregularities, and that might improve the vision in these cases. But most often it is better to avoid toric lenses if you have a gross irregular astigmatism, which is as such difficult to manage.
Absolutely.
Yeah. Any other comments from any other?
I would just like to say a final word here. Like, the students should not go with the idea toric lenses are difficult. In fact, they are the choice of procedure nowadays for all cataract surgery. If you look into today's number of cases we operate, the toric lenses have taken over. Like I started with 7%, 10%, and now with the multifocality coming there, your toric implantation has increased significantly. More than 50 to 60% cases may require toric lenses, and they are quite forgiving also. Like, I'm not sure about the too much of trifocality, but monofocal toric lenses, whatever you do, they see patient does very well. And surgery is not difficult. Now you saw in this study also they have not used the image guided system. They use the manual marking. Despite that, they got such a beautiful result. So you should practice, and it is a way forward for a toric lens implantation.
I think yes.
Yeah.
Dr.
One-
Himanshu sir, any comments?
While
Yes, sir.
deciding toric IOL for keratoconus, we use Retix classification.
Okay.
So it's a very good classification. It is actually oriented in such a way that it will help us decide what procedure to go for. It's a fantastic classification. Retix, RETICS.
Yeah.
Yes. Can I, sir, how are the results with Indian toric lens?
Whatever I have used, they have given a good results. And it's not that they are poor. I've used Oral Lab, I've used IOCare lenses. They are all hydrophobic designs now.
Yeah.
And they've done a very nice outcomes, not much of deviation.
Monofocal toric gives good result, but I am not very happy with the Indian multifocal.
Yeah, that part, my experience is very less. I've not used them that much.
You have any experience with the optical biometer by company Tomy?
I'm sorry, we don't have that. But I got today, people from, biomedics. They are coming with the new biometer, which gives almost entire posterior cornea mapping. Like we have anterior and gives slightly more than the IOL Master 700, and that will give you almost 11 millimeter radius, and that would give the best analysis.
So with this newer toric, surgeons are very happy. So the question of taking axis, main port at the steeper meridian is no more.
Yeah, I think very nice point. Like once you do a toric implantation, as we discussed the SIA, so you have to be, your incision has to be every time in the same place, same size, so that whatever SIA you have on your case will be, applicable. If you change your, axis of surgery to the steeper axis, then your entire calculation will go haywire. That would be acceptable if you are doing a corneal, incision modulation without using the toric implantation. So steeper axis flattening can be done by, both, opposite clear corneal incision or doing arcuate incisions, not for a toric IOLs.
Sir, I think probably if you have with the rule astigmatism and you are looking at a very small amount of astigmatism and you want to contemplate this patient whether we should put a toric versus a no toric, I think changing the position of the incision with limbal relaxing incision probably makes one patient, drop down from toric to non-toric level. So the cost factor comes down. I don't know. I do this for my practice. So most of the time it's possible with the rule astigmatism. But for against the rule, I usually don't do it because you know that you land up undercorrecting the ATR rather than overcorrecting. So I don't know the experience of the others. They can comment.
It depends. We have totally gone out of the incisional surgeries or shifting your incisions. In fact, now sitting superiorly has become challenge for us because we have totally become
Yeah,
a
it is difficult. It is difficult. It is
surgery.
only possible when you're sitting on the left side. You
Yeah,
can still go up to 70, 80. But sitting on the right side, yeah, I think it's a little difficult.
that sometimes that is a problem.
Yes,
So
sir.
that was a nice discussion which we had, and we are running
Yeah,
out of
sure.
time now.
Yeah.
So I would just
Right.
ask Dr. Neeraj to give a thank.
So I'd like to thank everybody who's on board today for our Journal Club Season 3, starting from Dr. Jeevan Titiyal, sir. Thank you for your time, sir. I think it's very difficult to get your time during such crunch time of AIOS, and all the best to you for the AIOS elections. Thank you to Vavikar, sir, for always being there and guiding us, always educating us and highlighting such good points. We would also like to thank Dr. Varshav Gore, sir, who is the HOD of MGM Kamote Hospital. Ishan, thank you for this amazing presentation. we always have Dr. Sunny Santa sir, who has always made sure to pinpoint the minute biostatistical changes in every paper that we are going through. Of course, the backbone of the journal club, that is Parul madam and Vaishal Kenya sir, and Dr. Zain Khatib and I, who would also like to take this opportunity to invite everybody for the next journal club, that is on 24th of April, and we hope to bring another interesting topic on board. Thank you, everybody.
Thank you.
Thank you, everyone. Thank you, Bhavika sir. Thank you,
Thank you, and good night, good evening to all of you.
Night,
Thank
sir.
you. Thank
Right,
you.
right.
Bye bye.
Bye-bye.